Hello friends. Welcome back to this series of lectures on cardiology for MBBS students. If you have still not subscribed to this channel, this is the time that you hit the subscribe button. In my last video we covered stable angina, and today we will cover acute coronary syndrome. Acute coronary syndrome is a term that includes both unstable angina and myocardial infarction. Unstable angina is characterized by new onset or rapidly worsening angina, angina on minimal exertion, or angina at rest in the absence of myocardial damage. In contrast, myocardial infarction occurs when symptoms occur at rest, and there is evidence of myocardial necrosis, as demonstrated by an elevation in cardiac troponin. An acute coronary syndrome may present as a new phenomenon, or against a background of chronic stable angina. The culprit lesion is usually a complex ulcerated or fissured atheromatous plaque with adherent platelet-rich thrombus and local coronary artery spasm. This is a dynamic process whereby the degree of obstruction may either increase, leading to complete vessel occlusion, or regress due to the effects of platelet disaggregation and endogenous fibrinolysis. In acute MI, occlusive thrombus is almost always present at the site of rupture or erosion of an atheromatous plaque. The thrombus may undergo spontaneous lysis over the course of the next few days, although by this time irreversible myocardial damage has occurred. Without treatment, the infarct-related artery remains permanently occluded in 20 to 30% of patients. The process of infarction progresses over several hours, and most patients present when it is still possible to salvage myocardium and improve outcome. Clinical features. Pain is the cardinal symptom of an acute coronary syndrome, but breathlessness, vomiting, and collapse are common features. The pain occurs in the same sites as angina but is usually more severe and lasts longer. It is often described as a tightness, heaviness, or constriction in the chest. In acute MI, the pain can be excruciating, and the patient's expression and pallor may vividly convey the seriousness of the situation. Most patients are breathless, and in some this is the only symptom. Indeed, MI may pass unrecognized. Painless or silent MI is particularly common in older patients or those with diabetes mellitus. If syncope occurs, it is usually due to an arrhythmia or profound hypotension. Vomiting and sinus bradycardia are often due to vagal stimulation and are particularly common in patients with inferior MI. Nausea and vomiting may also be caused or aggravated by opiates given for pain relief. Sudden death, from ventricular fibrillation or asystole, may occur immediately and often within the first hour. If the patient survives this most critical stage, the liability to dangerous arrhythmias remains, but diminishes as each hour goes by. It is vital that patients know not to delay calling for help if symptoms occur. The development of cardiac failure reflects the extent of myocardial ischemia and is the major cause of death in those who survive the first few hours. Diagnosis and risk stratification. The differential diagnosis includes most causes of central chest pain. I have covered the assessment of acute chest pain in my previous video, and it depends heavily on an analysis of the character of the pain and its associated features, evaluation of the ECG, and serial measurements of cardiac troponin I or T. A 12-lead ECG is mandatory and defines the initial triage, management, and treatment. Patients with ST segment elevation or new bundle branch block require emergency reperfusion therapy. In patients with acute coronary syndrome without ST segment elevation, the ECG may show transient or persistent ST or T wave changes, including ST depression and T wave inversion. Approximately 12% of patients will die within 1 month and a fifth within 6 months of the index event. The risk markers that are indicative of an adverse prognosis include recurrent ischemia, extensive ECG changes at rest or during pain, the release of troponins, arrhythmias, recurrent ischemia, and hemodynamic complications, example hypotension or mitral regurgitation, during episodes of ischemia. Risk stratification is important because it guides the use of more complex pharmacological and interventional treatment. Investigations. Electrocardiography. The ECG is central to confirming the diagnosis but may be difficult to interpret if there is bundle branch block or previous MI. The initial ECG may be normal or non-diagnostic in 1/3 of cases. Repeated ECGs are important, especially where the diagnosis is uncertain or the patient has recurrent or persistent symptoms. The earliest ECG change is usually ST segment deviation. With proximal occlusion of a major coronary artery, ST segment elevation, or new bundle branch block, is seen initially with later diminution in the size of the R wave, and development of a Q wave in transmural infarction. Subsequently, the T wave becomes inverted because of a change in ventricular repolarization. This change persists after the ST segment has returned to normal. These sequential features are sufficiently reliable for the approximate age of the infarct to be deduced. In non-ST segment elevation acute coronary syndrome, there is partial occlusion of a major vessel or complete occlusion of a minor vessel causing unstable angina or partial thickness, subendocardial MI. This is usually associated with ST segment depression and T wave changes. In the presence of infarction, this may be accompanied by some loss of R waves in the absence of Q waves. The ECG changes are best seen in the leads that face the ischemic or infarcted area. When there has been anteroseptal infarction, abnormalities are found in one or more leads from V1 to V4, while anterolateral infarction produces changes from V4 to V6, in AVL and in lead-I. Inferior infarction is best shown in leads 2, 3 and AVF, while at the same time leads 1, AVL and the anterior chest leads may show reciprocal changes of ST depression. Infarction of the posterior wall of the LV does not cause ST elevation or Q waves in the standard leads, but can be diagnosed by the presence of reciprocal changes, ST depression and a tall R wave in leads V1 to V4. Some infarctions, especially inferior, also involve the right ventricle. This may be identified by recording from additional leads placed over the right precordium called right-sided leads. Plasma cardiac markers. In unstable angina, there is no detectable rise in cardiac markers or enzymes, and the initial diagnosis is made from the clinical history and ECG only. In contrast, MI causes a rise in the plasma concentration of enzymes and proteins that are normally concentrated within cardiac cells. The most sensitive markers of myocardial cell damage are the cardiac troponins T and I, which are released within 4 to 6 hours and remain elevated for up to 2 weeks. Admission and serial estimations are helpful because it is the change in plasma concentrations of these markers that confirms the diagnosis of MI. Other blood tests. A leukocytosis is usual, reaching a peak on the first day. The erythrocyte sedimentation rate (ESR) and C-reactive protein (CRP) are also elevated. Chest X-ray. This may demonstrate pulmonary edema that is not evident on clinical examination. The heart size is often normal, but there may be cardiomegaly due to pre-existing myocardial damage. Echocardiography. This is useful for assessing left and right ventricular function and for detecting important complications such as mural thrombus, cardiac rupture, ventricular septal defect, mitral regurgitation and pericardial effusion. Immediate management, the first 12 hours. Patients should be admitted urgently to hospital because there is a significant risk of death or recurrent myocardial ischemia during the early unstable phase, and appropriate medical therapy can reduce the incidence of these by at least 60%. Patients are usually managed in a dedicated cardiac unit where the necessary expertise, monitoring and resuscitation facilities can be concentrated. If there are no complications, the patient can be mobilized from the second day and discharged from hospital after 3 to 5 days. Analgesia. Adequate analgesia is essential not only to relieve distress, but also to lower adrenergic drive and thereby reduce vascular resistance, BP, infarct size and susceptibility to ventricular arrhythmias. Intravenous opiates, initially morphine sulfate 5 to 10 mg and antiemetics, initially metoclopramide 10 mg, should be administered and titrated by giving repeated small aliquots until the patient is comfortable. Intramuscular injections should be avoided because the clinical effect may be delayed by poor skeletal muscle perfusion, and a painful hematoma may form following thrombolytic or antithrombotic therapy. Antithrombotic therapy. Antiplatelet therapy. In patients with acute coronary syndrome, oral administration of 75 to 300 mg aspirin daily improves survival, with a 25% relative risk reduction in mortality. The first tablet, 300 mg, should be given orally within the first 12 hours, and therapy should be continued indefinitely if there are no side effects. In combination with aspirin, the early within 12 hours use of clopidogrel 600 mg, followed by 150 mg daily for 1 week and 75 mg daily thereafter, confers a further reduction in ischemic events. In patients with an acute coronary syndrome with or without ST segment elevation, ticagrelor, 180 mg followed by 90 mg 12-hourly, is more effective than clopidogrel in reducing vascular death, MI or stroke, and all-cause death without affecting overall major bleeding risk. Lipoprotein 2b3a receptor antagonists such as tirofiban and abciximab block the final common pathway of platelet aggregation and are potent inhibitors of platelet-rich thrombus formation. They are of particular benefit in patients with acute coronary syndromes who undergo PCI or those with recurrent ischemia and those at particularly high risk, such as patients with diabetes mellitus or an elevated troponin concentration. Anticoagulants. Anticoagulation reduces the risk of thromboembolic complications, and prevents reinfarction in the absence of reperfusion therapy or after successful thrombolysis. Anticoagulation can be achieved using unfractionated heparin, fractioned or low molecular weight heparin or a pentasaccharide fondaparinux. Comparative clinical trials suggest that the pentasaccharides, subcutaneous fondaparinux 2.5 mg daily, have the best safety and efficacy profile, with low molecular weight heparin, subcutaneous enoxaparin 1 mg per kg 12-hourly, being a reasonable alternative. Anticoagulation should be continued for 8 days or until discharge from hospital or coronary revascularization. A period of treatment with warfarin should be considered if there is persistent atrial fibrillation or evidence of extensive anterior infarction, or if echocardiography shows mobile mural thrombus, because these patients are at increased risk of systemic thromboembolism. Anti-anginal therapy. Sublingual glycerol trinitrate, 300 to 500 microgram, is a valuable first aid measure in unstable angina or threatened infarction, and intravenous nitrates GTN 0.6 to 1.2 mg per hour or isosorbide dinitrate 1 to 2 mg hour are useful for the treatment of left ventricular failure and the relief of recurrent or persistent ischemic pain. Intravenous beta blockers, e.g. atenolol 5 to 10 mg or metoprolol 5 to 15 mg given over 5 minutes, relieve pain, reduce arrhythmias and improve short-term mortality in patients who present within 12 hours of the onset of symptoms. However, they should be avoided if there is heart failure, pulmonary edema, hypotension, systolic BP less than 105 mmHg or bradycardia, heart rate less than 65 per min. A dihydropyridine calcium channel antagonist, e.g. nifedipine or amlodipine, can be added to the beta blocker if there is persistent chest discomfort but may cause an unwanted tachycardia if used alone. Because of their rate-limiting action, verapamil and diltiazem are the calcium channel antagonists of choice if a beta blocker is contraindicated. Reperfusion therapy. Non-ST segment elevation acute coronary syndrome immediate emergency reperfusion therapy has no demonstrable benefit in patients with non-ST segment elevation MI, and thrombolytic therapy may be harmful. Selected medium to high-risk patients to benefit from in-hospital coronary angiography and coronary revascularization, but this does not need to take place in the first 12 hours. ST segment elevation acute coronary syndrome. Immediate reperfusion therapy restores coronary artery patency, preserves left ventricular function and improves survival. Successful therapy is associated with pain relief, resolution of acute ST elevation and sometimes transient arrhythmias, for example idioventricular rhythm. Primary percutaneous coronary intervention (PCI). This is the treatment of choice for ST segment elevation. MI outcomes are best when it is used in combination with glycoprotein 2b3A receptor antagonists and intracoronary stent implantation. In comparison to thrombolytic therapy, it is associated with a greater reduction in the risk of death, recurrent MI or stroke. The universal use of primary PCI has been limited by availability of the necessary resources to provide this highly specialized emergency service. Thus, intravenous thrombolytic therapy remains the first-line reperfusion treatment in many hospitals, especially those in rural or remote areas. When primary PCI cannot be achieved within 2 hours of diagnosis, thrombolytic therapy should be administered. Thrombolysis. The appropriate use of thrombolytic therapy can reduce hospital mortality by 25 to 50%, and this survival advantage is maintained for at least 10 years. The benefit is greatest in those patients who receive treatment within the first few hours, minutes mean muscle. Alteplase, human tissue plasminogen activator or tissue plasminogen activator, is a genetically engineered drug that is given over 90 minutes, bolus dose of 15 mg, followed by 0.75 mg per kg body weight, but not exceeding 50 mg over 30 minutes, and then 0.5 mg per kg body weight, but not exceeding 35 mg over 60 minutes. Its use is associated with better survival rates than streptokinase, but carries a slightly higher risk of intracerebral bleeding. Analogues of TPA, such as tenecteplase and reteplase, have a longer plasma half-life than alteplase and can be given as an intravenous bolus. Tenecteplase is as effective as alteplase at reducing death and MI whilst conferring similar intracerebral bleeding risks. However, other major bleeding and transfusion risks are lower, and the practical advantages of bolus administration may provide opportunities for prompt treatment in the emergency department or in the pre-hospital setting. Reteplase is administered as a double bolus and also produces a similar outcome to that achieved with alteplase, although some of the bleeding risks appear slightly higher. An overview of all the large randomized trials confirms that thrombolytic therapy reduces short-term mortality in patients with MI if it is given within 12 hours of the onset of symptoms, and the ECG shows bundle branch block or characteristic ST segment elevation greater than 1 mm in the limb leads or 2 mm in the chest leads. Thrombolysis appears to be of little net benefit and may be harmful in those who present more than 12 hours after the onset of symptoms and in those with a normal ECG or ST depression. In patients with ST elevation or bundle branch block, the absolute benefit of thrombolysis plus aspirin is approximately 50 lives saved per 1,000 patients treated within 6 hours and 40 lives saved per 1,000 patients treated between 7 and 12 hours after the onset of symptoms. The benefit is greatest for patients treated within the first 2 hours. The major hazard of thrombolytic therapy is bleeding. Cerebral hemorrhage causes 4 extra strokes per 1,000 patients treated, and the incidence of other major bleeds is between 0.5% and 1%. Accordingly, the treatment should be withheld if there is a significant risk of serious bleeding. For some patients, thrombolytic therapy is contraindicated or fails to achieve coronary arterial reperfusion. Early emergency PCI may then be considered, particularly where there is evidence of cardiogenic shock. Hope you enjoyed the video. Do not forget to like, subscribe and share the channel. Do post your comments and queries related to the topic and stay safe.